So the last case that I wanted to present is a pseudophakic patient, and this patient had a membrane peel with SF6 gas in the left eye 4 weeks ago. Of note, this patient had a macular hole in the other eye a couple months ago, and their vision at presentation is 2100. And this is sort of what they look like prior to surgery. They're 20/60. And you can see on some of the cuts over on the left that the hole is indeed full thickness. And this was before their initial surgery, but you can see that the hyaloid is there pulling up on things. And this is what they looked like after they had that membrane peel, and the vision had declined to 2100. So this is a technique. This is a surgery that I did with our fellow Dr. Kakor, who is now in practice at Vanderbilt. And you can see that we were able to put our ports in. I put in sort of catalog to see to make sure that there wasn't any hyaloid that was still persistent there or any sort of vitreouschisis. You can see that we actually, the first round actually did a really wide peel, but I tried to see if I could do a hinge ILM flap for this patient. So I used the flex loop to be able to mobilize any sort of remaining ILM that's there. And you can see that there's really not a lot that's there, but Hadi, our fellow, was able to do a really nice job and using first the flex loop and then using the ILM forcep to be able to create this hinge flap. You can create a free flap too, but I think I feel like my chances of getting the hinge flap to be able to stay into position are higher than using a free flap. So we're just sort of gently working, peeling the ILM across to be able to create this ribbon. And, the entire time I'm doing this, I'm afraid that this is going to truncate, but it actually went really nicely. I then use a Tano scraper to just be able to mobilize the edges of the macular hole, make sure there aren't any sort of adhesions that are there. And so we're able to do that pretty nicely. Then I do a really good shave, make sure I got everything that's present. And then I use viscoelastic actually to be able to put the ILM flap where it's supposed to be. So you can see I got it in good position and using the soft tip. And then I'm able to put in a little bit of viscoat in order to be able to keep it in position there. And then when I go to my air fluid, it's staying nicely. You can see that my view gets a little challenging. I have to put some viscoat on the back of the lens implant. And then I'm able to really get a good air fluid exchange and keep that flap in a good position. So I was able to do this. I put in C3F8 for this eye. This is what they look like post-op month 1. A little hard to get a great OCT because the patient still has that gas bubble, but you can see that the tissue has started to come back together. I suspect that that's the ILM flap that's present, sort of bridging, but you can see that the outer retina is sort of encouraging to come back together. This is what they look like post-op month 3, where the hole is indeed still closed. And this is what they look like actually a year afterwards. So they're 20/40 and had a good anatomical result as well. So thank you so much for listening to this presentation. I'm looking forward to our discussion. I try to include here some different maneuvers that we can use to tackle some of these challenging macular holes that we happen to see in clinic. Obviously, just doing a good standard ILM peel works really well for most of our macular holes, but it's nice to know what other tools we can have in our toolbox available to us in these cases of more challenging situations.